Hello everybody, my name is Damian Griffin. I'm a hip surgeon specialising in young active people with hip problems, including golfers. And my practice is based in Warwick and in London. And for nearly 20 years I've been running a sports hip clinic, looking after a wide variety of problems around the hip in young people. I think you can see some of them listed here, and you'll recognise a lot of the issues which challenge us in managing sports people today. One I'm particularly going to talk about today is femoroacetabular impingement syndrome. I want to share with you some of the things we've discovered about this in golfers. So the first thing to understand is that the forces on a golfer's hips are really enormous. So a professional golfer hits around 200 balls in a practice session and plays around 76 rounds each week. Now we know that the impact of this on their body can be very considerable, and we know about problems in the wrists and in the spine and in the knees. But until recently, there wasn't much thought about what might be going on in their hips. And yet the hips forces are large. So if you put a golfer into a gait analysis machine with force plates and you measure what's happening around their hips, what you particularly discover is that in the lead hip, the rotational torque reaches 230 degrees per second during a drive, and that's a force equivalent to catching about 500 kilograms in your arms with them outstretched. Now, there are big forces on both hips, but it turns out that the lead hip is the one that takes the greatest punishment. And we know that golfers compensate when they develop pain around their hips, and you will be aware of all the different patterns of compensation that you might see during a swing. And many of these seem to be due to either weakness or stiffness affecting their hips. I'm going to present some data now from a couple of papers that we published a few years ago in the British Journal of Sports Medicine. And I'll put these papers and others that I talk about today onto my Twitter account. So if you go there, you'll be able to check them later on. These two papers, I'd like to particularly recognise my PhD student, Ed Dickinson, who worked with me, but also with Phil O'Connor, radiologist, and with Roger Hawkes, who all of you will know, to assess professional golfers. So our first study was looking at a group of golfers in the England golf squad. And we assessed 34 golfers, some women and mostly men. They're all pretty young. They've been playing for a mean of about 11 years, and they play pretty hard, so 27 hours of practice each week. And we were interested in discovering how often they felt they had hip pain. And what we found out was that 5 of the players, that's 15%, complained of hip pain which had troubled them for at least a day in the last month. Now that seems more than we were expecting, so we looked at it a bit more closely and we used a patient-reported score, the IHOT, that's the International Hip Outcome Tool, which is designed to measure hip symptoms in young athletic people. And we found that they were scoring around about 90 out of 100 on the IHOT score. 100 is the maximum possible score, and that means your hip is perfect. 0 is a score that's very, very bad indeed. 90 is a surprisingly not that great score. We thought that these athletes would have scores closer to 100. But you can see there's a big range as well. Some are scoring down as low as 50 or even 40, which is really a very symptomatic hip. Now the second study we did was in the European Challenge Tour. So when they came to play at the Hydro in Scotland, 156 players were registered, and we were able to get 70% of them to fill in questionnaires on symptoms, including the IHOT score. And we did clinical examinations on 73 of those 109, and MR examinations on about half of them. So we took an MRI scanner to the tour. Now these players are a little bit older than the Golf England players, 29 average age, been playing golf for an average of nearly 20 years, and they were completely full-time. They were practicing for 38 hours a week. They're pretty healthy, so BMI around 25, but notice there's quite a big range, and we'll pop back to that later. Now 21 of these players, so 19%, that's a similar percentage, 15% in the England group, 19 in the European Challenge Tour, were complaining of hip pain. And we looked at the IHOT scores of their lead and trail hips, and you can see the distributions there. It turns out that the lead hips were a bit worse than the trail hips. And that was statistically significant, but not very obviously clinically significant. But we got an inkling here that the lead hips might be a bigger problem. Now, on clinical examination, we found that quite a lot of them had positive impingement tests. That's the Fadir test. Also pain on Faber testing, which is often a good indicator of a very inflamed hip. And here the lead hips were frequently worse. Internal rotation range was similar on the two sides, but you can see there's a big variation amongst the players. We'll come back to that. Then I mentioned we had the MRI scanner there as well, and you can see my PhD student, Ed Dickinson, and Roger Hawkes there standing in front of it. And we measured a range of metrics in the shape of both the lead and the trail hips for these players. And what we found is that the lead hip tended to have more space at the front of the joint. And that more space was created by an increased head-neck offset, and that's measured with the alpha angle, which you can see is 53 degrees, substantially lower, so more space than the trail hips at 58 degrees. And by more femoral antitorsion, so the femoral head is rotated forwards in a resting position, which gives, and that shape gives the player more internal rotation range. So this was pretty exciting because here we had found a morphological difference between the two hips in golfers. This is something we'd hypothesized might exist given the very one-sided nature of golf, but had previously never been shown in any athletes. So what we've got is that in the European Challenge Tour players, quite a big sample, there's an increased femoral head-neck offset and an increased femoral antitorsion in the lead hips compared to the trail hips. And that's advantageous to give the lead hip more internal rotation. But also, we've discovered that lead hips are often more painful than trail hips and are more likely to give the player problems. Now, when we looked at association between the patient describing hip pain and various patient factors with a multiple linear regression, we found statistically significant associations between hip pain and cam shape, low torsion, a longer career, and higher BMI. So if you've got a hip that has less head-neck offset, a cam shape, and low torsion, and therefore less space at the front, so it internally rotates less well. And if you've played for a longer time, so I would suggest beaten up your hip more, and if you're bigger and heavier, so you put bigger forces on the hip, this combination makes you most likely to present with hip pain. So this is interesting. We've discovered that in golfers, very one-sided type of sport, the two hips are different. Usually the lead hip allows more range of internal rotation. Perhaps that's been brought about by playing lots of golf when you were young, or perhaps it's been the case that only people with lots of internal rotation in their lead hip can become good golfers. But in any case, if your shape is not that favourable, and especially as you play more golf, and especially if you get a bit bigger and put bigger forces on your hip, then you can run into trouble with pain more often in the lead hip. So let me show you a typical patient to put a bit of illustration around this. So this is a real player, a real patient of mine. It's the most recent professional golfer I've treated earlier this year. You may well recognize who it is, and he's given me permission to tell you about him. So he's a 24-year-old man. He's left-handed, and that means that his right hip is his lead hip. He played as an England international for 2 years and had 5 caps for the men's team, and finished his amateur career with a rank of 58 in the world. In 2019, he turned professional and has played in various tours, including the European Pro Tour and tours in the Middle East and Far East. Now, when he thinks back, about 4 years ago, he started to notice clicking in his right hip. This wasn't a big problem for him, but it was uncomfortable, and sometimes he had a sharp catching pain, which led him to catch his breath or stumble a little bit deep in the right groin. But he also had some aching pain, and the aching pain was, he indicates with a C sign, like the picture here, a deep pointer sign where he points into his groin, and he explained that it's really deep inside. He couldn't put his finger on the pain. Now, in late 2021, this pain all got worse, and particularly it was troublesome when he was swinging, and particularly when he was driving. So not too bad for walking or running, but big issues playing golf. So a major issue for this professional player. By January 2022, he decided that he could barely play and couldn't really continue with any further training or tournaments. And that's when I met him. Now, very briefly, he had very poor single leg control on the right side. So the muscles which he'd been using to compensate for this problem had finally decompensated. Terminal hip flexion was painful and brought on his familiar pain, and he had restricted internal rotation in flexion. And an impingement test was positive. We did a plain radiograph, and if you look really closely on that picture, you'll see there's a slight bulge at the femoral head-neck junction on this AP view. Not a very sensitive test because the shape abnormality is usually around the front of the hip and not visible on an AP picture. And in fact, you'll see that his left hip has got a similar subtle shape. So now we have to think about what's the diagnosis, and here's another paper I'll put on Twitter. This is the Warwick Agreement, which we published a few years ago in the British Journal of Sports Medicine. It enables one to determine whether a patient really has a diagnosis of femoroacetabular impingement syndrome. And you can see here that there are 3 areas that we want to capture. Firstly, symptoms. So yes, our patient has symptoms of hip pain with clicking and catching, and sometimes you'll see stiffness and giving way. He has clinical signs on examination which are consistent with femoroacetabular impingement syndrome, with a restricted range of movement and a positive impingement test. And he has radiological findings, at least on that plain radiograph, that give a hint that this might be the right diagnosis. So he meets the requirement of a triad of symptoms, signs, and radiological features. But you can see that the next box there is to do some additional imaging. And I like to do this myself because we've developed specific protocols to use for it. So here you can see firstly an MRI scan on the left-hand side there. And if you look closely at the rim of the acetabulum, you'll see that there is a tear of the labrum. This CT scan in 3D reconstruction shows a cam shape, and you can see what I meant about it being at the front of the hip, and it's blocking hip movement by restricting the amount of space available at the front. And you can see it more clearly here in this profile view where I've rotated the image. You can see that it's clearly a bulge of bone where there should be a head-neck recess. So I would call this a cam shape or low head-neck offset. Now going back to our diagnostic triad, once we've completed that imaging, we may well then want to do a local anaesthetic injection test. And I do like to do this, especially in these sort of high stakes decisions. If we do an operation in this young man, that's going to take him out of playing and therefore earning for several months. So I inject some local anaesthetic into the hip joint under X-ray control with sedation. And before I do that local anaesthetic to numb the hip joint, I'll get him to do some exercise. And in his case, the ideal thing is to have him do his swing, which we did. Had to take him outside and then just swing his golf club a few times, and he would say, yep, that's the pain I get. Then we can repeat that swing after we've blocked his hip with the local anaesthetic, and sure enough, in him, all his pain went away completely. So we could be confident that his hip was the source of his pain. The other advantage of doing this is that whilst I have the patient sedated and with an image intensifier, I can look at the movement of the hip under the image intensifier. And you can see the cam shape here banging into the edge of the socket and preventing the hip from moving more freely. And you can see why that would damage the labrum and eventually the articular cartilage. So back to our triad, I think we clearly got a diagnosis of femoroacetabular impingement syndrome, and we can think now about treatment options. And there are several possibilities. Well, conservative care, he tried all that, he didn't want that, he wanted to move on. Physiotherapy, we know physiotherapy can work, and often it's a decision as to whether we do physiotherapy or surgery. And we've got more and more data now to support us in that. This was the first very large trial done comparing physiotherapy and surgery for hip impingement. It's called the Fashion Trial, published in the Lancet. I'll put it on Twitter, and it clearly comes to the conclusion that both strategies can help, but that surgery has a greater probability of providing benefit. So we went ahead and did arthroscopic surgery for him. This is keyhole surgery. It requires quite a lot of kit and facilities to make it work, but it enables us to repair the damage inside the hip. And then perhaps for this presentation, most relevantly, to reshape this golfer's hip so that he has more space at the front of the hip and can therefore rotate his hip inwards with a greater range and without pain and damage. So this operation took about 2 hours, and then he got up and walked out of the hospital later that day. Now I wanted to talk to you a little bit about his recovery, because naturally you'd be wondering how long will it take for him to get better and get back to play. So this is the sort of protocol that I give to my patients and that I discuss with physiotherapists who are working with me. And you can see that I've got 4 overlapping steps here. First thing is to make sure the patient has a quiet hip, and that usually takes 4 or 6 weeks. And by that I mean that the inflammation around the hip, any bruising or swelling, has all gone away. The wounds have healed, the stitches are out, and the patient has a really easy, comfortable, free range of movement with no restrictions. So that's a quiet hip, and until we've got that, we don't do anything more. That's the foundation we'll build on. Then we work on training the small muscles around the hip that control the hip joint and achieve stability of the hip. Then the bigger muscles, so the big power movers, and then finally get all of that working in a coordinated way so that the hip is able to deal with dynamic stress. So can he run, jump, land, twist, and absorb impact? And then the patient, the player, will be ready to train for competition. So how did that work out in our golfer? So if we put a spectrum here of the first 16 weeks after surgery, that's how I'd sort of expect it to go. And this is what happened. So there's that spectrum. He didn't pick up a golf club until 6 weeks. And then he went out onto a golf course and started with just a short game. So just putting and then a little bit of chipping. He used a 6-iron to start with, and at 7 weeks, he was aiming for a carry of 65 yards, which he achieved. And then progressively, 8 weeks, you can see 80 yards, 100 yards, 120 yards, and 150 yards at 11 weeks. So he's coming towards the end of 3 months, and he's already able to carry the ball 150 yards with a 6-iron. Then he started to use his driver. So this is his number 3 wood. And at 12 weeks, he could achieve 250 yards. And by 16 weeks, when he considered he was fully recovered, 290 yards. So there I think you can see the sort of spectrum of improvement you might reasonably expect. Now he measured his swing speed, which is interesting, I think. So with a 6-iron, 91 miles per hour is the best he had ever achieved in his career before the surgery. At 12 weeks, when he first started to drive, so he felt he was pretty comfortable with his 6-iron, he was achieving 88 miles per hour. And then, as you see over the next few weeks, he gradually speeds up and gets eventually to 93 miles per hour. So a bit better than he had achieved before the surgery. The driver, again, his career best up to that point was 114 miles per hour. After surgery, he achieves 117 miles per hour, which he tells me gives him about another 7 yards on a drive. Now, I think that's all interesting, and it's helpful perhaps to you if you're rehabilitating someone. But of course, the key point for this player was that he'd been in so much pain before the surgery that he could no longer train or play. Now he absolutely can. So his first tournament was at about 13 weeks. He feels he wasn't really ready for that, but by the time he played at 16 weeks, he reckons he was 100%. And you can see, remember he's a left-hander, you can see that his lead hip internally rotates, and he can do that without pain anymore. If you can't see quite how far that's internally rotated, just have a look at his foot there. So to conclude, on average, professional golfers have different lead and trail hip shapes. That was really surprising. We thought it could be the case, but we'd never measured it before these studies. They have more head-neck offset and higher torsion, which allows the lead hip to internally rotate more during the swing and therefore develop more power. Now, golfers who don't have this shape but are trying to get more power may well get hip pain. And we've seen that that number could be 15 or 19%. So maybe as much as a fifth of golfers are going to get hip pain, most often in the lead hip. So takeaway message for today is golfers can get problems with their hips, and they can be important. So try to recognize them and then refer them to someone appropriate to investigate that hip pain. If it does turn out to be femoroacetabular impingement syndrome, which I think is probably the most likely diagnosis in a young player, then I've shown you that it can be fixed with a predictable recovery. The player can return to at least the performance they had before, and maybe even a little bit better. Thank you very much.
Well, thank you very much, Professor Griffin, for speaking to us.
Hello, everybody.
Virtually.
My name is Damian Griffin.
We may have Professor Griffin on some audio if it has worked out for the Q&A. Professor Griffin, can you hear us? We can't hear you just yet. Are you muted?
How's that? Can you see me and hear me?
That's excellent. Thank you very much, Professor Griffin, for that talk. We're sorry you couldn't be with us live. I know you did try. We're just going to go to the floor.
I do apologise. I've been beaten off by buckled railway lines, and I'm in Devon with appalling internet connection. So hopefully we make this work, and if we do, it's a real achievement.
Thank you. You're not the only person to struggle to come up from England, so don't worry. The rails were working against you. Do we have any questions for Professor Griffin based on that talk? And if so, could we use the microphone just so he can hear us? Yeah. Dan, do you mind? Super. We're just passing the microphone to the audience so you can hear the questions.
Brilliant. Thanks very much.
Just click it
Hi there, Prof. Can you hear this?
I can, it's very clear.
Thanks very much. There's obviously significant differences in the anatomical appearances of the pelvis in women versus men. Did you find any significant differences there in golfers? And if so, what are they? And does that pose a different challenge to you?
Yeah, that's a great question. First part of the answer is we didn't find any differences because we didn't look at women using the MRI scans. So we were just doing men on the challenge tour. We need to study women still. I can tell you from sort of wider experience that women tend to have more antitorsion in their femur, and they tend to have a shallower acetabulum. And both of those things make them less likely to suffer impingement. And that's why fewer women end up needing surgery for hip impingement. I suspect the same applies to golfers, and so women may be relatively protected compared to men. But whether that's actually true or just my hypothesis, we've yet to find out.
Have we any other questions? Saskia?
I have one. Well, you're showing that it's pretty good able to return to golf after surgery and even on the same level or higher. Well, I've been working on a rehab protocol also for hip arthroscopy, and I've been reading that following last studies, only 21% of sporters are able to return on the same level or higher. So why is it that the golfers are so good able to return to golf, and in other sports it's not possible, even on ACL reconstructions and stuff like that? So
yeah, so I'd love to hear from you actually. If you're working on a protocol, please send me a tweet or an email, because it'd be great to talk to you. In respect to the answer to your question, I am aware of the studies you described which talk about a relatively low return to sport rate. And I wanted to show that, at least in this patient, as a case example, and he just happens to be my most recent professional golfer, it was really clear that he did get back to sport at least the level he was at before. I don't think we should really compare this sort of hip surgery with ACL reconstruction. I think this is more almost cosmetic surgery of the hip, rather than treating a major injury like an ACL rupture. I think you've got a better chance of returning to sport after this surgery than you would have after an ACL reconstruction. Now, why is it that some authors have found that a small proportion of athletes getting back after hip arthroscopy have been able to get back to their previous level? I think the biggest reason for that is probably that in any series you look at, a high proportion of the athletes having surgery are in a very bad situation. They've got very badly damaged hips. In many cases, having an operation is the very last thing that they do to try and save their career. And my suggestion is that we are making a mistake there. Although we don't want to rush to surgery, and none of us want to do that, we should be open to the idea of identifying those who are at severe risk of damaging their hips. And at the early stage, when they first present with some symptoms, we should think about treating them. Because I do think our chance of getting them back to the high level that they wish to be at is much greater if we treat them where their damage is less. And that was the case with the player I showed you. So I guess my answer to your question is, a lot of people don't get back because when they have their surgery, it's already too late. And we can all do something about that.
Okay, time for one more question.
Thanks, Professor Griffin. Fantastic talk. Ian
Hello.
Murray from Edinburgh here. Can I ask a boring technical question about your approach to capsular management and whether having a professional golfer would affect your approach to closing the capsule if you are an interportal capsulotomy person? And secondly, does that affect your rehabilitation if you do close the capsule? Or would you recommend, if someone was closing the capsule, would that affect your approach to rehab, whether there's a brace, no brace, etc.?
Sure. So this is a pretty current question, as you will know. For those in the audience who are not aware of it, part of the operation to access the hip joint is to open the capsule, make a little window in it. When we started doing this sort of surgery, we didn't really have the capability to repair that incision in the capsule. So lots and lots of patients had surgery without having the capsule repaired. And on the whole, they did pretty well. Now we definitely can repair the capsule. It's a bit of a fiddle and it takes a few minutes to do it, but any competent surgeon will be able to stitch the capsule back together again. And my thinking on this is, if we've cut through the capsule and we have no concerns about the capsule itself, then as part of closing the operation, we should repair the capsule with some sutures. And so I do that in most patients. I certainly did that in the patient that you've just seen. The circumstances in which I don't close the capsule are those where the capsule is very tight. And there are some professional athletes where that's the case. So I think, for example, of a couple of weeks ago, I treated a professional rugby player, and he had really the beginnings of arthritis in his hip with a thickened and tight capsule. So closing the capsule didn't really make any sense. I just left it open as part of a means to enable him to get more range of movement. With respect to rehabilitation, I think if you close the capsule in a reasonable fashion, you can go straight to full rehabilitation. I don't use a brace. I don't put any limits on the patients. So I still go for that first 4 weeks or so of aiming for a quiet hip before we start putting any big forces on it. But I don't make any special provision because I've closed the capsule. So my routine now is close the capsule unless it's very tight, and whether I close it or not, get the patient moving early with no restrictions.
Professor Griffin, thank you so much for your time. We're going to have to move on so everyone can slip a coffee break in before the last session, but we really appreciate your efforts for joining us virtually today.